Hi guys, I'm back, and this time we're going to talk about junctional rhythms. There aren't very many junctional rhythms, so this one is a little bit shorter. The main thing you need to know about junctional rhythms is how to recognize what a junctional beat looks like. Okay, so we have to think about where the beat is coming from. This is the junctional area around the AV node. So when I say junctional, what I'm talking about is kind of around the AV node, the junction between the atria and the ventricles, and the right side of the heart and the left side of the heart. So the four corners area, that's the junction. That's the big intersection. All right, so let's say that we have a heartbeat that originates from a cell in the junctional area. Right in here. We have a cell right here. What would happen if we had an ectopic focus and a cell right here fired and made a heartbeat? So we know that electricity would spread in both directions, right? So the question is, what would depolarize first, the atria or the ventricles? Well, going this way, the electricity is going to go to the AV node and travel the normal bundle branch system. So the QRS is going to be skinny and normal looking, less than 0.12. But what's going to happen to the P wave? Well, that's kind of the question. So electricity is going to travel backwards, retrograde, up towards the atria. And there's kind of three possibilities for what might happen with the timing. As electricity travels both directions, either it's going to be slower because it's traveling against, like cell to cell to cell to cell up here, but it's like fast on the bundle branch system down here. So it could depolarize the ventricles first, like boom, 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 boom. But it has a shorter distance to go to the atria. So maybe the atria first, boom, boom. Boom, 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 boom. Or maybe it'll be simultaneous. Boom, boom, boom. So there's three possible looks to a junctional beat. The P wave could be before the QRS, during the QRS, or after the QRS. So let's see what that would look like in each case. In the first case, let's have the P before. So if the P was before, it would mean that the atria depolarized right before the ventricles. But the electricity is traveling retrograde to the atria, and so the P is going to be upside down in lead 2, and they're happening almost at the same time. So the P is going to be really close to the QRS. So the P is going to be upside down in lead 2 and really close to the QRS. So PR less than 0.12. Normally it's supposed to be 0.12 to 0.20, but it didn't come from the top and go to the middle and wait, and then go down to the bottom. It came from the middle and went both directions. And one of the reasons we know when we look at this measurement and we see how short it is, we realize electricity didn't start at the top and go to the middle. It went in the middle and went both directions. We know that from the short measurement. And then another clue is the fact that the P is upside down in lead 2, where everything is usually upright in lead 2. So that's one possibility of P before. Another possibility is that they'll depolarize simultaneously. So you would have an upside down P, and you would also have a QRS occurring at the same time, and then a T wave. But because the QRS complex is much bigger, it's going to bury the P wave, and you're not going to see it at all. So what's going to happen in this case is you're just going to have a flat line, normal looking QRS and a T. So you'll just have a flat line, a normal looking QRS and a T. That is by far the most common type of junctional beat. So when you see this, no P, but a normal skinny QRS and a T, you think, hey, that looks like a junctional beat. Then the last possibility is the least common, which is for some reason it was really hard for electricity to go retrograde, but it was easy for it to go down the bundle branches. So actually, it depolarized the ventricles first. So you got skinny normal QRS, upside down P after, and then a T. This one can be hard to see because sometimes it just really seems like maybe this is how the T wave goes. It's just like this. In which case, you just think that there's no P, and you still think it's junctional. So you'd still call it the right thing. So it's not that big of a deal. So not very common, but sometimes we see it. So P can be before, during, or after. If the P is before, it will be upside down and very close to the QRS, meaning PR is less than 0.12. No P is the most common looking junctional beat, where it's just a flat line and a skinny QRS. So when you see that, you say, hey, that looks like a junctional beat. All right, that is a junctional beat. Now, let's talk about the most common junctional rhythm that you might see, and that is a junctional escape rhythm. So it's not ectopy. It's not a cell that's fizzy and annoyed and ectopic and starved for oxygen. I'm talking about a situation where something has happened to your sinus node. Where did it go? Did you have a contusion to the sinus node? Did you have digitoxicity to the sinus node? Did you have an MI and you infarcted the sinus node? What the heck happened to your sinus node? Where did it go? So whatever happened to your sinus node, it has failed to fire. And the AV node, which has been waiting its entire life for its chance to show what it can do, it has been waiting to step up and provide a heart rhythm, albeit only at a rate of 40 to 60, finally has its moment to shine. And so one of the cells in here somewhere, whichever one has the most automaticity and can go the fastest, finally gets to begin a junctional escape rhythm. The most common looking is no P, so that's the one I'm going to draw because that's probably what you'll see. And it's probably going to be at a rate of 40 to 60. So it'll just be a flat line, nice looking regular QRS, kind of slow, rate of 40 to 60, flat line. These are all supposed to be the same. It's just hard for my hands to draw it, but all QRS is the same. They're all normal. Flat line. Flat, whoops, that's too close. Flat line. Not too fast, just nice and slow. Okay. So when you first look at the strip, what you'll say is it looks pretty regular. The rate might be a little slow, somewhere between 40 to 60. Then you go, is there one P for every QRS? And you're like, no. In fact, there aren't any Ps at all. But the QRSs are skinny and normal, and that is when you go, hey, this is a junctional rhythm. The fact that the rate is between 40 and 60 tells you this is a junctional escape rhythm. No Ps, regular QRSs, rate 40 to 60, junctional escape rhythm. So, how does a patient feel? It's completely dependent on their ventricular pulse rate. Well, really, that's your only pulse rate. Your ventricular rate is your pulse rate. You don't have any other type of pulse rate besides that. It's dependent on their pulse rate. So if it's close to 60, they probably feel fine. If it's like 40, they probably don't feel very good. So that really is determining. Now, they lost their atrial kick, obviously. So if they already had a very low cardiac output and then they go into a junctional escape rhythm, then that also could make them symptomatic. If they had a good cardiac output and they lost atrial kick, then that might not cause them to have symptoms. So it's a little bit relative to what their baseline is and then what their pulse rate is, determines if they have symptoms or not. Let's say they are symptomatic. So I'd say they already had a crappy cardiac output and the pulse rate of this, or the ventricular rate on this is only 44, and you go in and they're having chest pain related to the low rate. It's not good enough. What do you think we would do? Well, we have some options. Because usually what students will say now is to give them medications. They'll say like, give them epinephrine, or pump them up with drugs, get them revved up, give them Red Bull. But usually we'll probably go to a pacemaker, because this happens because your sinus node has taken a vacation. And so the thing to do is to support your conduction system while we figure out like what the heck happened to your sinus node. So it usually support them with pacemaking while we try to figure out where your sinus node went and rectify that situation. But you can try a drug out on them and see how they do with it, but drugs are temporary, so then it's going to wear back off, and then do they go back down to a 42 beat per minute? This again, well, then you can't just keep, we can't just keep them on drugs forever unless it's just a really temporary situation. Then maybe that would work. So, okay, junctional escape rhythm is a temporary thing. So nobody is going to be able to walk around all day long or for the next month in a junctional escape rhythm. It's always like a temporary fix that your body's doing for you to keep you going until this guy comes back from wherever he is, or something, or we get you a permanent pacemaker, or figure out what your problem is. This is just a standby. So this is junctional escape rhythm. The other thing your body might do for you is, a lot of people might be in a junctional escape and your body gives you a little bit of adrenaline to speed up the intrinsic rate. So they'll be in something that looks exactly like this, but the rate will make its way over 60 beats per minute. It'll look just the same. It won't be too much higher. It'll be above 60, but it's not going to ever go over 100 or anything like that. And we're going to call that an accelerated junctional, whoops, that's a D, junctional escape. Which makes sense. It's just your body trying to come up with enough cardiac output for you. And it's pretty temporary, because anything that's being driven off of adrenaline is not a long-term solution. But it's a good compensatory mechanism. It'll work for a while. Could you go into junctional tachycardia over 100? Yeah, there is such a thing as junctional tachycardia. That is usually an ectopy. So that's usually a dysrhythmia where the cell is in fact ectopic, and I would call that a pretty advanced type of dysrhythmia. So it's not that common. It's something that we see in cardiology or in the EP lab. It looks like SVT. Skinny QRS, one lump, skinny QRS, one lump, skinny QRS, one lump. When we see that, we almost always just say SVT, because the treatments are exactly the same. If they're stable, we do vagal maneuver, we go to adenosine if that doesn't work. If they're unstable, we cardiovert them. So functionally, it looks very much like SVT. If you're a cardiologist, you can get a 12 lead and you can differentiate between junctional tachycardia and other types of SVT. But as far as a nurse responding to a patient, Junctional tach is pretty advanced type of dysrhythmia, and so I don't think we even really need to go there. But a good thing to know about is junctional escape rhythm, and that sometimes it could even go over 60 and be a little bit of an accelerated junctional tach. Those are good, not junctional tach, a little bit of an accelerated junctional escape rhythm. Those are good things to know about. Sometimes you don't get a whole junctional escape rhythm. You just get a couple of junctional escape beats, which really makes sense. When would you need that? You need that when you start having like a really big pause, right? So somebody's going along and they're in sinus rhythm, and then for some reason they have one of those pauses like we were looking at on strips, and it's just getting long, and you're like, Lord, that's getting to be a long pause, and then they just have one of these beats in here, no P wave, skinny QRS and a T, and then sinus rhythm resumes over here with some P's and QRS's and T's and stuff. Sinus rhythm, that's terrible. Let me try better. Okay. Sinus rhythm resumes. So sometimes when there's a long gap, you'll get like one junctional escape beat, or maybe one or two. And you're like, thank goodness for that, right? Because if this one beat wasn't in there, then the pause would have been this long. So that's what your AV note is supposed to do. It's a backup. When you're like, okay, we're getting into 40 to 60 territory right now, I'll just throw one in there so we can have like a pulse. And then sinus node, wherever it took a nap or whatever, came back and then resumed beating over there. So you don't have to have a whole junctional escape rhythm. A lot of times you just get a junctional escape beat or two. All right. That's it. That's it for junctional. Next, heart blocks.